Hey y'all, happy Thursday. As promised, you get a little bit of video content to fill in the days that we don't actually get to see each other. You get to enjoy it in the comfort of your own situation and hopefully maskless. So this week's materials are getting into the social dimensions of health, or as some people also refer to them as the social determinants of health. Dimensions and determinants might seem like splitting hairs, but there's actually important reasons why we would use different words. And what I want to relate this to is some of the concepts from last week and my video from last week. So if you haven't had a chance to check it out, it's 20-ish minutes and talks a lot about the distinction between population and public health. Also ties into what we actually talked about in class this week in terms of value systems and how that impacts what we actually get to know in public health research and information, and then therefore what we disseminate in public health information and research. But first I want to get back to determinants versus dimensions. So in the past, social determinants of health have been something that we have acknowledged as being the pieces of health influence, health behaviors, health environments that contribute to the outcomes in certain populations within our larger public and our communities. So for instance, speaking about healthcare access. So a lot of these things actually came up in our discussion in class on Tuesday, healthcare access and access to healthcare things, as we called it, meaning healthcare clinics, healthcare providers, labs, medication. So things that we associate with healthcare access, but also just associate with healthcare, period. And that what it feels like and looks like to receive healthcare. That's one determinant of health. Environment. So this came up in our class as well. Clean air, clean water, not living by a power station, not living under power lines, not living near a major roadway or highway that actually provides a lot more pollutants in your immediate environment. All of those things are under sort of the environmental arm. Thinking about social, cultural, racial, religious, ethnic, linguistic contributions. So how speaking a different language than the primary language of a place that we live can impair or impact our health outcomes. As I mentioned in class the other day, I mean, medicine in and of itself is a whole other culture and language. So truly speaking, we all are becoming literate in healthcare language as we become patients. But most of us, and if some of us are in healthcare, but most of us don't start off our lives being fluent in healthcare language. In and of itself, there's a cultural dissonance right there. And how does that impact our healthcare outcomes when it's not even a matter of doing the quote unquote right things, but understanding in a language that is intelligible to us, whether it is literally the primary language of the area that we live or the difference between healthcare language in that language and our own language, what those health behaviors mean and what the impacts are. Thinking about other pieces of, other determinants of health, like health policy. How do policies then trickle down and affect our immediate well-being? What if, for instance, going back to things like redlining, how did those end segregate and other policies that promoted segregation or policies that kept other groups like women out of certain situations? How do those policies then affect our health? We're seeing that happen live, right? Not only with the pandemic, but with certain policies that came down in Texas related to abortion access. How do those policies affect health? Well, when people have a limited access to certain elements or all elements of reproductive care, how is that going to affect the reproductive health of 51% of the population? It's going to be impactful, right? Thinking about not just the health behaviors, like diet, exercise, all that kind of stuff, but the access to those things. So food scarcity, food deserts are also one contribution or social determinant of health, because the neighborhoods that we get to live in, or the neighborhoods that we've historically been permitted access to, can then determine whether or not we have healthy foods, can then determine whether or not we're able to eat those healthy foods, and then achieve those health outcomes that people associate with better health. Those are all examples of how of what social determinants of health are. There's lots of diagrams out there. If you were to Google social determinants of health, you'll get all kinds of grids. Some have 5, some have 8, some have 12. Really, the number of them is sort of irrelevant. It's more so to get an idea of what are we talking about when we say social determinants of health, because what we're talking about when we say that is where can we tackle some of these determinants of health. Maybe they don't get tackled in the healthcare context, although they should. It seems like medicine and healthcare is oriented towards like, what is the biochemical physiologic thing that I can tackle while you're here with me? It's unfortunate that our healthcare system isn't really well poised and that most healthcare providers aren't educated. They are not educated in social determinants of health such that they can actually address those confidently and efficiently and with the right amount of support and services to actually make a difference with those. That most patients are left to fend for those determinants of health on their own. Or to say, well, your health behaviors are affecting your health. Great, but do you know that like my income, my housing, my environment, my food scarcity is actually all impacting my ability to even engage in that health behavior? People know that intellectually. It's actually borne out in the research in so much detail and for so many years, but it hasn't quite infiltrated the healthcare interactions. And so that's where we see a lot of those disparities happen in healthcare, is the social determinants of health and then the physiologic biochemical determinants of health, and how they are acknowledged, addressed, supported in a healthcare context or not, and most of the time not, to the detriment of certain populations. I want to go back to the idea of determinants versus dimensions. Determinants, is based on the word determine, determination, determined. The idea that these factors or features of our lives, our housing, our access to healthcare, our proximity to healthcare, or healthy food, determines our health versus being a dimension of health. Determinants has kind of like a sedentary connotation to it, with dimensions having a lot more mutability. It's something that can change. And so we have shifted from using social determinants of health to social dimensions of health, which is actually a topic of an entire class that you're going to take, or maybe are taking congruent with this class. And so you're going to get into this in much more detail. So I like to give an introduction to it for those of you who are not yet at that course, or maybe you're in your minor, or haven't actually selected health studies as your major. Given the demographic of this class, it seemed like most people were determined health studies majors. So you're going to get way more depth with this information. And having taught that class many times before, I can tell you that there's a lot of really cool stuff we get to do with it in terms of really digging into the literature and like, what do we know? And why doesn't this become part of the healthcare interaction? I mean, honestly, with the amount of evidence that's out there, it's almost kind of criminal that it's not part of healthcare interactions more often. This is one way, as a consumer and as a patient, you can really push providers to understand that, like, hey, I am not my numbers on that page. I am not even actually solely my health behaviors that you have determined are negatively impacting my health. That I am an amalgamation of many dimensions of my social constructs, including the inequities and disparities and racism and sexism and misogyny and discrimination that I experience, the level of poverty that my family and my community has experienced intergenerationally, the amount of trauma that I have experienced and that my community has experienced for many years, my immigration status, my refugee status. There are so many things that impact our health that we know about that aren't necessarily included there. And one of the pieces that is gaining a lot more traction is the concept of ACEs and trauma, and the concept of trauma-informed care. So I'll put a few more resources in with this video related to ACEs and trauma-informed care. They really should be, in my opinion, their own little bubble on those social dimensions of health diagrams, because of how impactful we know that adverse events or traumatic events when we are younger impact our long-term health. That those events, they stay with us physiologically. That stress response that our body manifests becomes a replicated pattern over time, which isn't to say that we have no agency there, that we can't actually rewire those patterns, that there isn't something that we can do about it. But we are not solely our health behaviors. We are not solely our numbers in terms of health outcomes. We are absolutely a conglomerate of all the dimensions of our health, every single one of us, regardless of whether we are in a group or community or population that is thought of as disparate or treated inequitably. We are still an amalgamation of all the other things that have happened to us, all our stresses, the level of poverty or trauma that we have experienced, or the lack of instability that we've experienced, or the lack of stable family unit that we've experienced, which crosses all economic lines and all races and all languages. So as we get into thinking about healthcare communication strategies, I want you to start to look at and look around in your environment. How often do we talk about populations of people that we are concerned about, disparate and disparate populations that are treated inequitably, from the perspective of what happened to them? What did we do to them? Historically, currently, how much of this is a larger communal responsibility and how much of this is only individual responsibility? So this comes back to what we talked about in class on Tuesday, which is, what is our underlying viewpoint? Is it all for one and one for all? Is it, we're all just for ourselves and we pull ourselves up by our bootstraps? On some level, that bootstraps mentality really is shot down by the concept of social dimensions of health, that there is no such thing as bootstraps, only certain people are given those bootstraps. And then on some level, we all can learn and earn bootstraps, but those are going to come from equitable, helpful, connected, caring people and interactions in our environment that actually, hey, I have some bootstraps. Would you like to borrow them? So that you can engage with healthier behaviors that will improve your health outcomes, as opposed to, well, I went through hard stuff and I'm fine. Newsflash, you're not fine. No one is. I think that there are a lot of ways that we proceed as a country, that even though we talk about public health, really a lot of our underlying philosophy and how we engage with healthcare, how we offer healthcare, and how we just offer care, period, has a lot to do with, I'm for me, you're for you. We're a very individual, autonomous, autonomy-oriented society. Not necessarily a bad thing, but when we proceed with health conversations, health care conversations, from the perspective of, I want health and care for you, but I want you to do it yourself, it really does make the concepts of public health very, very challenging. So to really do public health well, we kind of have to discard that notion of individuality and only individual values matter and autonomy is, of highest priority on some level, in order to really see how our behavior, our history impacts another person's ability to even access health and care and better outcomes. We can't really have a conversation about population health if we're not having a conversation about social dimensions of health. We can't really say, well, we would love the maternal mortality and morbidity, so the death and the long-term consequences of birth affecting Black women in America. We can't say that we want that to improve if we're not looking, if we're only saying, well, Black women, you just got to get healthier in pregnancy. Gosh darn it, just do that already, okay? We actually have to look at all the different ways that we impair their ability to live, to have really positive outcomes after having babies, or simply from pregnancies itself, because it's one of the most common complications for Black women in this country is just their pregnancies themselves. And it's not because they're inherently unhealthy or that they're making worse decisions in their pregnancy. There are so many other social contributions to that. So we can't address public health. We can't address population health. We can't actually see improvements of those things if we don't actually look at the social dimensions of health, and we don't look at our history of what we do and what we have done to large groups of our community, large groups within our community, and really kept them from even having a glimpse at health and care, let alone accessing it and thriving within it. And that's really the crux of what it means to look at social dimensions of health and what the implications are for public health. The next piece we have to think about is health communication strategies. Well, we can say, well, the way that we communicate with people is potentially as if their health is their fault. So if we really look at social dimensions of health deeply and really ingest that messaging, it would radically change our messaging too, in terms of what you can do to achieve health. Well, what you can do to achieve health is really our society can get the heck out of your way so that you can actually get to the things that would improve your health. And many of you probably have examples of this or have seen it play out. I know that my patients definitely have, and it's one of the reasons they seek me out as a type of provider who spends time with them and literally looks at every single dimension of their life as part of their decision-making process in their healthcare. I can recommend something to them, but if that's not actually feasible in terms of money, transportation, longevity, family life, then what's the point of recommending that to them and then blaming them for not getting the outcome? I didn't actually do a thorough examination of my patient if I didn't look at their social dimensions of health. You were not thoroughly examined. Your family members were not thoroughly examined by a healthcare provider if they didn't look at every single dimension of your health, not just your labs and your blood pressure and your BMI, which is crap, which you already know. So we will also take a look more into healthcare communication strategies that take social dimensions of health into consideration, and what it would look like from a public health perspective to communicate with that in mind. So think about, even just from the context of the pandemic, what would it look like if we communicated with people about their risk, not just from their race, their age, or their body size, but really from the perspective of what can we do to remove obstacles for you such that you can engage in this public health endeavor. Because a lot of the messaging out there was totally blame oriented. If you have a bigger body, dying from COVID. If you're a brown or black person, definitely gonna die from COVID. If you are over 85, you're pretty much dead, so I don't even know why we're having this conversation. We addressed populations from a public health communication strategy is like, we've identified the populations at risk, but why are they at risk? Because we neglect them. We didn't address our neglect. And that's really what the difference would be if we integrated social dimensions of health into public health communication, addressing our ownership, accountability, and frank neglect of populations within our community. So I want you to think about that. I want you to look around at public health communication related to the pandemic, related to reproductive care, maybe even in your own family experiences or personal experiences of how providers have communicated with you, and how little of the dimensions of your life that were considered, or someone's life that is dear to you, was considered in the healthcare information that was provided, and how much that could have changed the outcome if it had been addressed. There are a couple bits of information on the modules. I really want you to take a look at that. I'd love for you to watch that video on the cliff analogy and get a little bit more clear on this thing that we're talking about. Next week, one of my colleagues and another faculty member, Jen Zagadelli, who also teaches in the health studies curriculum, she and I are going to do a little activity with you. We're actually going to look at some of these things and like real time, and actually dissect them together as a group, and maybe even start to dream about and think about how we would do these things differently as a group. You don't have to come with the answers. I just want you to come with the willingness, the curiosity, and a little bit of this perspective. So enjoy your weekend. Make sure to get through your materials. You got a quiz, you got a reflection. You're more than welcome to go back and work on the things you haven't submitted yet, because I haven't graded them yet. That's my plan for the weekend. And I hope you have a good weekend while you're at it. Bye.